I'd like to welcome Dr. Sasha Laskowicz, Dr. B, back today. Welcome, Dr. B.
Thanks
Last
for
time
having me
we
in.
last time we met, it was 7 a.m. your time, and you were chipper, alert, and very enthusiastic. So I know you have a passion for this work for your patients.
Absolutely, yeah.
Today we'll be discussing possibilities for imaging the craniocervical junction in Canada, and hoping that we'll be able to provide patients with some detail and guidance where there is limited guidance in the Canadian healthcare system. Before we begin discussing the options, could you provide insights as to how imaging may assist patients in guiding and directing their care and future treatment plan?
Sure. I think delineating what is wrong with an individual, especially when we're considering that there's a biomechanical problem at hand, more than likely, is that it's really hard to run a gamut of orthopedic and neurologic tests, especially in the gray area patients that aren't blatantly obviously having a massive neurological problem. Is that you need imaging to be able to isolate subtleties that would not be expected to be seen on an x-ray, for example, or type of imaging on a patient who is asymptomatic. And so these subtleties are the tip-offs, visible tip-offs, that there is a likelihood that the symptoms that this patient is presenting with have a biomechanical nature to them. And then when you see the subtleties, you can, add on to that and do more specialized imaging that would hopefully provide more definitive answers to be able to guide the treatment process better for patients. So simply just doing a physical exam, an interview with a patient, getting their history, it's a great start, but it's rarely definitive unless they're in a very severe case with neurological compromise that even the most standard tests either aggravate their symptoms or significantly reduce their symptoms. But you would still then, in order to, if there was a severe case that would require potential surgical triage, they would always require diagnostic imaging to validate what they're dealing with before they go and slice or poke holes in people to go and fix things, because they never, as far as my understanding goes, base their surgical acceptance just off of a clinical presentation and some orthopedic neurologic tests. They always have to validate with some form of imaging that is specific to the neurosurgeon or the surgeon that's dealing with it. Some will require CT scan, some will require MRI, some will require x-ray, but they will all, from my experience so far, require something in addition to just the patient's clinical presentation and list of symptoms and the results of the orthopedic neurologic tests.
Yeah, Dr. B, I think it's helpful that we started with a severe case because the severe cases are more clear, as you indicate, and they may be more likely to be able to define what the problem is and some kind of causation to, for example, their neck or localized area.
Right.
Some may or may not end up finding an upper cervical chiropractor, but imagine those that end up looking for a neurosurgeon. Could you help patients? Because for some of them, they may think that one neurosurgeon is akin to another, and that is not the case. We need to explain the skull versus other types of neurosurgery, vascular, and so on. Can you speak to that?
Yeah. So neurosurgery basically would be anything that would involve, in general, so this is a generalization, the spine and skull as it pertains to impingements or infringements upon the neurological system. You can also have neurosurgeons that do peripheral, which is outside of the spine. But when you're looking at specifically this sort of upper cervical region, you would most likely want to be dealing with somebody who's a cranial base or a skull base neurosurgeon, whose focus is basically the junction between the skull and the spine, so the upper cervical spine. A lot of them, if not all of them, deal with the rest of the spine as well neurosurgically, but they generally, what they say is they have an interest or they have a specialty in that region because they tend to see a lot of cases or deal with a lot of cases that way. But it would definitely be a skull-based surgeon, and even in the skull-based surgeons, you have a variation in philosophy and experience in observation, what they've observed as far as what they think the pathology is or what they see the pathology to be, and then how they assimilate their fix of that pathology. So, for example, you'll have skull-based neurosurgeons that will tend to always involve the skull in their surgery. So if they do a upper cervical fusion surgery, they will always go skull C1, C2, and sometimes C3. And then you have other neurosurgeons that, in their experience and in their belief and in their philosophy, they will omit dealing with the skull base. So they won't actually do any fusion involving the skull to C1. They believe that the pathology doesn't occur there. And again, unless it's blatantly obvious, in which case it does, but they believe that it doesn't occur there, and that involving that in the fusion process and potentially even shaving the opening in the skull bigger to decompress neurology there or to take the pressure off of neurology there is something that they used to do, but now have deviated away from that based off of their observation of the results that came paired with that, and have changed their direction a full 180 to deviate away from there. So it's very case specific, it's very surgeon specific, and it's very much based off of the surgeon's utility of different types of imaging and what they're actually trying to look for in order to qualify a patient for the procedure that they're comfortable with and that they're proficient in and that they believe is going to be the best fix for the patient. So not it's so case specific that each case needs to be worked up very, very specifically and based off of both the patient's presentation and their findings off their imaging, but also then the neurosurgeon that would be best suited for that type of um, procedure. And always, I would say, a second opinion. So having two neurosurgeons that would be looking at the case and providing their input or more in order to be able to hone in on what would seem to be the best fit. And it's never a perfect science, but I think, approaching it that way, you'll get at least a little bit more information, because no one of them is all knowing and all perfect. We're all just human beings. And so they try to do the best with what they have and what they know and their experience has provided for them, and their training and education and continued education. So each case is very specific. And again, the basis is for this type of problem is that you're looking for a skull-based neurosurgeon.
Thank you. That's very helpful. In terms of the decompression, I too heard that we're filming in May 2024, and that's relevant because there is some information that also came out of Barcelona and a neurosurgeon that operates there, and I've heard the same about the decompressions. And today we'll talk more about the imaging and some of the other things that are being done. But I feel strongly that if there was any type of global initiative and some type of global force developed, then this information could be shared as to what's effective clinically, outcomes post-op, longevity, and some of the other complications as well. But hopefully one day we'll get there. So for today, let's just begin with a broad introduction as to what's available in our Canadian system and the public system, and how a patient might access care. And how would you guide patients through presenting with neck problems and or maybe trauma, but not investigated, where a patient doesn't appear to have anything broken? So let's talk broadly about that in the imaging, and then we'll get to some examples.
Well, the Canadian system has pretty much all of the imaging types of modalities at their hands. It's just where it becomes problematic is how they're being utilized. So I'll give you an example that I've been seeing a lot recently, is that even just the regular x-rays that people are getting of their neck when they're complaining about dizziness, nausea, vertigo, all the craniocervical types of post-concussive or MTBI type symptoms, they're being inevitably initially sent for a cervical spine x-ray. And what I've seen lately is that the open mouth view is being omitted. And I don't understand why, because even when I went through school, and the basic standard was a frontal view of the neck with the mouth closed, which then obliterates the ability to see C1 and C2. A side view, so at 90 degrees of the neck, so you can see everything. So you're seeing a three-dimensional being from the front, which is a two-dimensional view, and then from the side, which is a two-dimensional view, but that gives you a three-dimensional impression of a three-dimensional being. And then the third standard view was an open mouth, so that you could actually see C1 and 2 from the front, because you'll see them from the side on the standard side view. And that's generally what used to be the routine for the cervical spine. And what I'm seeing a lot more now is that the system, people, doctors in the system and the system itself is trying to perform a dynamic x-ray on patients, which is not really dynamic, it's positional. And so what that means is that the patient is bending their head down, they're taking a side x-ray or a view from the side. The patient then gets put neutral, they take another view from the side, and then they tilt their head back and they take another picture from the side. So one in maximum forward bending of their head, one in neutral, and one in maximum backward bending of their head. And then they omit the open mouth one, and then they'll do 45-degree views to catch all the holes in the neck that the nerves exit out of. So out of each hole, a nerve exits that is responsible for a portion of your shoulder to arm to fingers and back up. And again, omitting the open mouth, which tends to be by far the most important view for this type of patient category. And so that's the starting point that is being used by most physicians across Canada that I've seen. And I don't understand where the deviation away from the old standards, including the open mouth, went from, because if you think about it logically, you have 7 bones in the neck and you're doing a neck study. And the standard in radiology that has been around since its inception in 1895 is that you need to have, of a body part, you need to have 2 views at 90-degree angles to each other to be able to interpret in 3 dimensions this being that you can only look at 2 dimensions at one time. So you look at 2 dimensions from the front, 2 dimensions from the side, and that gives you a 3-dimensional concept of what's happening. And to omit the upper 2 bones by omitting the open mouth kind of goes away from viewing all of the structures within the region that you're studying at 90-degree angles. And so, again, I don't understand why that is happening more often than I've ever seen in the past, but it's become quite obvious that that is happening.
So from what I understand, there are a lot of rule outs by virtue of the omission of the open mouth positioning.
I don't know about rule outs, but just not able to rule in.
Right, right.
And
Right.
again,
Rule outs, but not necessarily rule in, right?
Right. And then you've got those 45-degree shots, which show the openings where the nerves come out of the neck at each one of the segments. And then that's being conducted on, for example, patients that are, and it's being conducted in neutral, so they're not stressing those positions at all. It's being conducted in neutral on 25-year-olds, 30-year-olds. Like, these people are not expected to have arthritic bone spurs in those foramen or foramina, those openings that would be impinging on separate nerves. So by looking at that in neutral and a 30-year-old, it makes no logical sense, because you would expect that degenerative changes in there to develop, in their 60s, 70s, 80s, and not in their 30s. So they're, when the system talks about you don't want to over radiate these patients and give them unnecessary, x-ray exposure, then they're doing illogical things are being done for an age category that doesn't fit the criteria for when you'd want to do that. And then things that are relevant, such as the open mouth view with someone complaining about, brainstem related symptoms, is being omitted. And that just makes absolutely no sense to me.
With X-ray imaging, would you also say that it doesn't properly reflect ligament tears, particularly where there's chronic scarring, where it replaces the thickness of normal cable-like
yeah, kind of, it can.
and the healthy ligaments?
Yeah, it kind of can and can't. So for example, what I just mentioned, them doing the dynamic, which is actually not dynamic, it's just positional. So bending forward x-ray, bending backward x-ray. That plane of motion is just the front to back plane, which is called the sagittal plane. So all you can see is ligaments that would resist movement in that plane. But then you've got side to side plane and you've got rotational plane. So if you're not stress positioning somebody in the side to side plane and seeing if you can see evidence of ligaments that are resisting or supposed to resist those motions, not resisting those motions, whereby you see vertebrae that have shifted out of their neutral position more than you would expect them to, and the same with the rotation one, you're only assessing 1/3 of the planes of possible motion. And you're defaulting and generalizing if you don't see anything abnormal on that, for example, or significantly abnormal, that there is no ligament compromise in the whole entire cervical spine. But literally, you're only checking 1/3, you're stressing 1/3 of the actual planes of motion and making a global statement as to the totality of either good or bad or pathologic or not pathologic, which again also doesn't make sense.
Right. Can you also take a moment to explain for individuals who are not so familiar and are at the early stages, dynamic versus static, and explain what that means?
Yeah, so dynamic would, by its definition, mean that something is moving. And like I said, the system terms what I just explained, so that bend your head forward, they take a picture, bend your head backward, they take a picture. Dynamic, but it's actually positional, because when they take the picture, you're in a static position. You are at end range, but you're not actually dynamically moving. You've reached an end range and they take a picture, then you reach the other end range, they take a picture. Whereas dynamic would be watching or following this motion from the back bend to the front bend throughout its totality. So that would be then a dynamic analysis of a dynamic structure. So you get to watch what the 7 bones do from point A to point B in its totality. Right. And so something that I, was oblivious to when I, before I started doing dynamic imaging, is that I made the assumption that the endpoint, for example, when you go into full bending forward and you take a picture, the assumption that I used to make, and that I believe the system is making still right now, is that you'll get the maximum amount of shift at that endpoint. And then when you take your picture at the endpoint, you're getting the full gamut of the abnormality, if you will. And what I found by doing thousands of motion x-ray studies is that oftentimes the abnormality will happen during the motion, and then when you get to the end point and hold there, it recalibrates a little bit. And the reason that happens is because we have a neuromuscular system that's coordinating all these movements, so the proper movements. And when you have instability, that when you reach the end point, the goal of that system is to basically try to mitigate some of that excessive movement. So when you get to the end point and hold, you're oftentimes, as far as my humble opinion goes and my observation of motion x-rays, is you're not getting the maximum abnormality generally. And when you have the ability to watch real time this occur, you can actually go frame by frame and then take your measurement when you see when you subjectively see the maximum, what looks to be the maximum amount of movement. And then when you proceed a couple of frames later, the measurement's less. So having the ability to dynamically track this motion and freeze it at the moment where it is maximal, and then take your measurement versus going to the endpoint and assuming that it's going to be the maximum at the endpoint. I used to believe that that was the case, but I've observed that that is generally not the case.
Thank you. That's helpful. Let's speak next about the MRI as a second public system option that's available to patients. Mm-hmm. And speak about some of the merits first, and then speak about some of the limitations.
Well, the merits are obviously because you can see all tissues generally when they do the different magnet sequences or magnet polarizations. You'll see, fatty tissue that'll be highlighted or watery tissue that'll be highlighted. And so it'll give you good contrast in the sense of being able to see, brainstem, spinal cord, blood vessels, discs, bones. But where you get into a limitation, unfortunately, is that the standard or routine for a neck is that when they do the side view of it, they'll go from midway in the skull to the first 2 or 3 bones in the mid back. So they'll get part of the skull, the whole neck, and then the first 2 or 3 bones in the mid back, you'll be able to see on the MRI. And when they do the top down slicing, they're actually going to omit, in general, they omit the upper neck because there are no discs there. So they'll start at C2-3 and then slice downward also to about, the second or third mid back bone. And then there's a slicing sequence that goes from front to back that is generally not conducted at all. And
so can you demonstrate again with your neck, just shift sideways where
Yeah.
the MRI imaging would stop at C2.
Yeah, well, here's the model. And
Yeah,
so,
and your neck. I find your neck helpful as well. The
yeah,
model's
well,
great, but most
so
patients
C2
are
is right about there.
Right.
So C2 is right about there. So they're going to go from there down, omitting this whole upper region. Again, because there are no discs there, and the general purpose or the general, reason that MRIs of the neck are being conducted are not for assessing, craniocervical pathology. They're generally done for assessing disc pathology. And because the upper third of the cervical spine does not have any discs, it's redundant to do it according to that protocol. However, when you have patients like we're dealing with, that is the essential part, that is the missing link and needs to be done. And again, like I said, the front to back slicing is completely omitted most of the time. And the top down starts at C2-3 and goes through the bottom of the neck. So it's only really the side view that you get of the entire neck. And there's no way to, and it's two-dimensional imaging. So there's no way to interpret, in 3 dimensions, what's happening at C0, C1, C2, based off of just the side to side slicing. You need to have top down and then front to back so that, again, you're looking in all 3 dimensions and you're observing that, upper neck region in all 3 dimensions. Because it provides a lot of information, because some ligaments go front to back, some go side to side, and some are, bent and twisted. So in order to be able to have the best chance at hopefully visualizing one of those not being there or being somehow compromised, so thinned out or grayish as opposed to black, you need to do all 3 planes, and they all need to incorporate that craniocervical junction, and it can be done. So this is a real simple fix, and it just takes whatever physician is requisitioning the MRI to notify the MRI facility that they want the entire cervical spine scanned in all 3 planes. That's all it takes. You want sagittal, axial, and coronal slicing sequences, and all 3 sequences must include the craniocervical junction. That's it. That's that simple. They can easily do that. And the radiologists all across Canada can easily provide a report and a signature on that, should they be asked to. And all it takes for the technician that's doing the MRI is to click the mouse and drag a bigger box that includes, the skull C1 and C2, or the bottom of the skull C1 and C2, into the slicing sequence.
And based on your experience, if the patient has requested this imaging of the craniocervical junction, which really gets missed in the most important part of the neck, as some well-reputed practitioners have indicated, have you found that the facility will image those 3 planes in accordance with the GP's instruction? Okay.
It's hit and miss, and I think it's partially because of the GP's instruction. I think the GPs are assuming that they're getting what they're getting, because generally the GPs are not ordering the MRI to look at themselves. They're just purely going off the written report. So when they request cervical spine MRI, even when, I would provide a note with the patient to tell the doctor that, they're not going to do the whole thing. You should add this into the wording. I have no way of confirming what they put in there, and they tell the patient, yeah, no problem, but there's no way. Well, there is a way, but it's too complicated to get, a copy of that requisition from the facility, especially as a chiropractor wanting to request it from a medical facility. They're friendly enough and kind enough to share the imaging when we request the imaging, but to share proprietary information with us, such as privileged information between the referring medical doctor, GP, and the facility, I think it'd be an uphill battle to do that. But I would suspect that it's hit and miss whether the doctor, the GP, transposes that information or that writing that I gave the patient to show the doctor onto their requisition, because I think a lot of them still have the assumption that everything's being done. So why would you need to specify anything? And I've never to this day yet had the opportunity, and I tell patients all the time, you can tell your doctor to call me and I can explain this all to them. But to this day, I've never had a phone call. So what I've had is, patients that have been told by the doctor, yep, we'll do that. And then when the imaging comes in, it hasn't been done. And so then the patient's, in a quandary, do I go back to the doctor and complain or try to get them to still, send me in for an addendum, or do we just leave it, suck it up and maybe, go pay privately for it, which you really shouldn't have to happen because it's, like I said, it can easily be done. And so, yeah, I have no way of confirming as to why it still doesn't get done, even when I provide them the information of it's not going to be done unless you ask for it. And if you ask for it, they can easily do it because it's not deviating some way from, like you're not asking for miracles. You're asking just for them to, enlarge the area of focus that they're looking at, which is actually part of the area that they're looking at.
Yeah, understood. Anything else on the public system before we move on to private pay options?
I mean, public system has CT scans as well, which are also relevant because you can actually see inside, just like with an MRI, you can, even though it's a two-dimensional imaging study, you can actually see inside because of the way it slices. But I would say an MRI is in most cases better for multiple reasons. There's no radiation, and you can see the soft tissue anatomy far better on MRI.
Okay, thank you. So just moving on to a couple private pay options, let's speak for a couple of minutes about the weight-bearing upright MRI. Is it fair to say that misalignments are more accurately demonstrated using an upright MRI? And as some literature indicates that good sensitivity in detecting the cerebellar tonsil ectopia, since the weight-bearing position exists, and it presents the cerebellar tonsils distended into the foramen magnum. And can you explain that area for patients as well?
Yeah, absolutely. So yes, to answer your first question, yes, theoretically, the upright should be able to show weight bearing, so gravity dependent subluxations or malpositions better. It should also be able to show better structures within the cervical spine or the head that when gravity is placed on them, like we are most of the day, we're upright, whereas most MRIs are made laying down. So it's not a recreation of our, usual daily positioning because we're not recumbent, we're not laying down beings, we're upright beings. And so assessing us upright is far more relevant than assessing us recumbent or laying down. And yes, so when you have that change in dynamic as far as where the gravity is coming from, you can see cerebellar tonsils and even disc herniations, which is the main reason why the upright MRI has been strongly utilized in the facilities that it's being utilized in, is to basically say when you're lying down, you're complaining about certain neurological symptoms, for example, in your hand, weakness, numbness, whatever. And when we do an MRI laying down, it doesn't really justify, surgically repairing anything because all you've got is a disc bulge. And it doesn't look to be impeding or infringing upon any neurological structures, obviously. So then when we sit you up or stand you up and we do that same imaging upright, wow, now you've got a full-blown disc herniation that is actually pressing up against your spinal cord. And now we can qualify you for fixing you. And so the upper cervical spine is not oftentimes being utilized, the upright MRI is not being oftentimes utilized effectively for the upper cervical spine. But to your answer, yes, it is a better way of assessing that region in general. But again, like I said at the beginning, the utility of the technology, so how it's being utilized by the lab or the clinic that's using it, is a much more important question than what can the actual technology do.
Sure, it depends on what is attached to the upright MRI at that particular location. And
Yeah.
so you can speak a bit about that, the head and neck coil. Some limited ones have the CSF flow studies. Those are less common. And then also, can you speak to the importance of the radiologist as well, which is a critical part of this puzzle?
It is. In order, you can have the evidence on the imaging, but a radiologist, a board certified radiologist, has to sign off on a report that basically evidences those findings in the report. And there's not a lot of board certified radiologists and neuroradiologists that have that have ample training or the desire to have that training as it pertains to the upper cervical spine. So most reports will read craniocervical junction appears unremarkable. And sometimes that is indeed unremarkable, and there's a significant amount of times where it's actually remarkable, and so the patient doesn't get served proper justice when there are remarkable findings, but yet the report reads as unremarkable, and that's simply because of the training and the experience generically in history not being focused on the upper cervical spine. When you're dealing with the neck, the discs are, if you look at the reports, like it quickly if it even does, it throws one little sentence about the craniocervical junction being unremarkable generally. And then you'll see very descriptive, C3-4, C4-5, C5-6, C6-7. They'll talk about the discs and circumferential disc bulges and, fissures and you name it, all very descriptive as it pertains to the discs. But then the upper cervical spine is just a generic, looks to be unremarkable. And so that's a very subjective term because it doesn't really describe anything.
Thank you. That's very helpful because this process of selecting where a patient may choose to have an upright MRI done is critical. So let's also speak about some of the limitations. But before we do that, I just want to say that since we are speaking Canada, we have one upright MRI available in BC. However, at this time that we're filming, the cervical ligament portion is not being read and the 9 measurements are not being taken, which I've confirmed with the neurosurgeon there. So it's important to know that where people are going to determine which location to go to if they do so choose upright MRI.
Right.
Let's talk about your thoughts about the imaging being blurred and unclear, and it's a 0.6 Tesla on the phonar.
It's either a 0.6 or a 0.8. I think they have 2 versions, and I'm not sure which version.
Okay,
I mean, I had the privilege
lower quality imaging is an issue, though, is it not?
To an extent. So what I was going to say is, in 2018, I had the privilege of spending 4 days with Dr. Demadian in New York, and he's the guy who invented MRI. And they were doing upper cervical or craniocervical syndrome, they called it, research. And so his technician there was able to tweak the parameters of the MRI where the clarity, to my surprise, was quite amazing. And so it is possible, but I'm not sure who has access to those parameters because it was proprietary research that was being done. But from what I recall, the actual quality of the images was quite superior even to the 1.5 Tesla stuff that I would normally see locally on the vast majority of patients that were having MRIs at that time, which was generally a 1.5 Tesla was sort of the cap, and now we're at a 3 Tesla is being much more prevalent. But as far as the upright, they were using a 0.6 Tesla in New York phonar, and the images were quite clear. So I believe that there is a way to splice or to tweak the settings on the scanner to provide more resilience in the anatomic structures.
And that is being done at specified locations as well. Good, thank you, that's helpful. Let's go on to speak about the DMX, which is a private pay option. And you can speak about some of the merits there. You have lots of experience in this area.
I do, yeah. So the motion X-ray is basically the truly dynamic version of assessing the cervical spine. And again, because generally chiropractors are the ones using it, and the protocol has become such that we understand that the biomechanics of any body region, you have to assess the biomechanics in all the possible planes. So like I was saying before, the system tends to omit 2/3 of possible movement in their so-called dynamic assessment. And so with the motion X-ray, the onus is to actually assess motion in all 3 planes. So front to back bending, side to side bending, and then the rotational component as well, so that the vast majority, if not all, the possible ligaments that would be suspending bones together in the neck in all the different directions of movement can be assessed and commented on.
Any cons you would say to the DMX regarding anything it wouldn't image or exposure maybe?
Well, the exposure is minimal, and we've had that tested multiple times, and every 3 years we get reassessed for that, and it always falls far below the norms for a cervical spine imaging study. And I would say it's not really a drawback because we're not trying to look at the detailed anatomy of the bones in the cervical spine. Is that the margins of the bones sometimes are not, perfectly visualized like you would see on a regular X-ray. But the benefit of doing this is that you can actually track in real time the complete motion. So if you're trying to assess somebody for a suspected fracture in the cervical spine, you wouldn't want to use motion X-ray. You'd want to do a plain X-ray that shows a lot more detail because there's a lot more of an intense radiation blast to look at that. Whereas the motion X-ray is a far more subdued radiation dose, but that allows you to be continuously, tracking throughout the full range of motion what's happening to the bones. So far less radiation as it's running, and compared to the regular X-ray, which is a huge blast of radiation, but it's for a snapshot. So when you work out the mathematics of those two things, they balance out. But what you can get from a motion X-ray that is wonderful is you can get about 2,600 still pictures from a complete study for the same amount of radiation that you would get from a 7 X-ray Davis series, like I just explained to you, that is being done regularly with the omission of the open mouth one. And so I think you get far more information, but you wouldn't want to be using it to rule in or rule out a fracture, suspected fracture.
And can you explain how the motion assessment will direct your treatment course potentially for the patient?
Yeah. You'll be able to tell whether their front ligaments are stretched or damaged, or their back ligaments are stretched or damaged, or the ones that go side to side, or the rotational ones. And you can tell between left and right, and is left worse or is right worse? Are they both equal roughly? And then that can dictate, for example, with the way I treat patients, which specific core muscles around that region I would focus on, so that there's actually less treatment being done. But because it's focused on the areas where the ligament damage is being evidenced by the motion X-ray, the efficacy of the treatment is far better than just trying to catch everything and seeing if dealing with all the muscles will provide relief. Because oftentimes the more you do, it's not necessarily better, and the result isn't better. And we've proved time and time again that when you can specifically see where the ligaments are damaged, you can focus in and hone in on those muscles. And as even just an attempt or a trial, just focus on those muscles and see what the results are of the treatment. And again, proven time and time again, doing less quote unquote treatment, or trying to treat less tissues, but focusing on the ones that would be suspected to be mostly affected by the ligament damage is shown to be quite a bit more effective than treating everything.
Thank you. So that provides you with a more precise direction.
100%.
And we'll speak more about treatment in the future. I just want to add that now that we are filming in 2024, it was just about a week ago that out of Barcelona, Spain, came some information regarding use of their CBCT scan, which I don't believe exists in Canada other than at the dentist's office. But they've developed protocols that they feel will be more widely accepted, and they believe that the imaging is better than an MRI, and certainly applies to those patients that cannot tolerate an upright MRI and end up in the ER, going directly to the ER after. So I want to say in the next year, their plan is to publish, to have a publication on CBCT protocols. So that's something that's upcoming, and that will be interesting because they say it's 1/10 the cost of an MRI and a lot less harm to the patient. So any thoughts on that?
Yeah, because again, we're assessing a biomechanical being. So doing the cone beam, especially in stress positions, you'll be able to, in a lot of detail, because the CT shows far more detail of the bony anatomy than the motion X-ray, the DMX does, albeit you're not assessing them dynamically, but ultimately, there are norms or expectations for how much rotation should be able to happen at a particular joint. And when you do that stress position with a cone beam, you can make perfect, measurements. You have great anatomy for landmarking, where you put your lines, where you can determine what the angulation is, and then compare that to the accepted, norms or upper limits of what's acceptable to be able to determine, again, indirectly. So these are all indirect measures of ligament damage. Neither the motion X-ray nor the cone beam CT nor a regular CT can tell you that the ligament is damaged, or show you, I should say, that the ligament is damaged by saying, okay, the ligament's supposed to be in this field of view here, but we don't see it. Therefore, it's gone. All you can know is we know the anatomy, we know what connects to what anatomically, and what the governed amounts of motion or limits to motion should be. So when you exceed that, the indirect reasoning is, deductive reasoning is that the ligament or the passive fibrous structure that's supposed to limit or govern that motion to that amount or to that upper reference range, because you've exceeded that reference range, therefore that fibrous connective tissue has to have been compromised to allow for that excessive motion to happen. So then you can indirectly infer that that ligament has been compromised, thereby this person has more mobility at that junction point, and based off of their clinical presentation of all the neurological symptoms that they could possibly be experiencing, you can say that that excessive motion is more likely than not, on a more probable than not basis, infringing upon their brainstem and nervous system, causing this layer of symptoms and this presentation that they have to be a cause and effect thing. And so the only true way of assessing, to visualize, hey, the ligament truly indeed is damaged, is by doing stress MRI.
Thank you for explaining.
But the cone beam CT is phenomenal. And yes, there are dentists in Canada using it for dental procedures. And from my understanding, there's been a couple of dentists that have agreed to do a few cervical studies when, strongly persuaded by a good friend who's a upper cervical chiropractor. And so that's, but there's no non-dental clinics in Canada that I know of that are utilizing this.
Thank you for your thorough explanations on deductive reasoning, and also the explanations on all the complexities around imaging in Canada and others. So thank you for your time today. Greatly appreciate your contribution to the community.
My pleasure. Thanks for having me.